Thank you, Rajlakshmi. I think Theo, you can take over.
Great, thank you. Thank you, everyone. And thank you for having me join on the session. So I'm excited for us to be able to talk a bit more about methadone and its use in pain management. So for our learning objectives will be to be able to describe the pharmacological properties of methadone, recognize appropriate patients for the use of methadone in pain management and palliative care, and identifying monitoring parameters for the safe use of methadone, being able to create a safe and effective therapy plan to initiate methadone, and then develop safe and effective plans to titrate or adjust methadone doses. Since there already were some pre and post test questions, I'll skim this past these sections. So when we talk about methadone and what it can be used for, there are a few indications that it's typically used for. The one use is for opioid use disorder. This is commonly used, and it was actually one of the primary initial uses in the US. But because of the nature of it being an opioid medication, it can also be used for pain management. And typically when we think of using methadone for pain, we think about using it for chronic, around the clock pain, and also has utility in patients with renal impairments. And it is also very effective for targeting neuropathic pain. And it also has additional benefits for patients that may be experiencing high tolerance or hyperanalgesia. And some of the common side effects with methadone includes constipation, sedation, hypotension, and urinary retention. With long-term use of opioids in general, but specifically with methadone, it also includes risk of opioid-induced androgen deficiency, immunosuppression, and osteoporosis. And some of the more serious side effects that we always want to be cautious and monitor around is respiratory depression, serotonin syndrome, QT prolongation, which could then lead to torsades. So diving a bit deeper into the pharmacology of methadone, it does have a few primary modes of action or targets. So it does work on the mu, delta, kappa, and opioid receptors as an agonist. And it also targets the NMDA receptor as an antagonist, and also works on the norepinephrine, reuptake inhibition, and also the serotonin or 5-HT reuptake inhibition. So these additional activities help with targeting neuropathic pain, and specifically with the NMDA antagonism, this is what also helps with neuropathic pain and also can help reverse some of these opioid tolerance and also hyperanalgesia that might occur with high dose opioid use. And then when we further break down methadone, it does typically come in a racemic mixture. And when we look at the different enantiomers, the S enantiomer is actually has a 3.5 higher affinity to affect the cardiac human ether agogo related gene and cause a blockade. So that in itself is what causes that more of that increased risk of QT prolongation by blocking delayed rectifying potassium channels. And when we look at its counterpart, the R methadone enantiomer, that enantiomer has up to an 8 to 50 times analgesic potency. And then in regards to pharmacokinetics, so this is an important concept when we talk about bioavailability. So when a patient takes a medication, how much do they absorb? So for oral availability, typically we would say that people It's around 80%, but it can vary depending on everyone's physiologic absorption. And when we think of pure sublingual absorption, it is only 30%. But for most patients, if you do administer sublingually, people are still going to be, or if you administer a liquid or syrup sublingually, people will generally still be swallowing it because it will trickle down their throat and go down the GI system. And just to be complete, I don't think it may currently be available in India, but methadone in the US also comes in an IV formulation. So if we do a conversion, we typically do a 1 to 2 conversion when switching from oral to IV, or a 1 to 0.5. And actually, when we switch from IV to PO, we do a 1 to 1.2. And this is to be conservative when we do dosing, because we can always titrate up if we need. But in regarding the activity of methadone, because it can improve opioid tolerance and hyperalgesia, the amount of opioids that is required when using methadone can be a little variable. And then when we talk about the more of the PK or the absorption, it does have a unique property compared to some other opioids. So when people typically absorb it, it does have a high lipophilicity. So it gets absorbed into the plasma and distributes pretty extensively into the tissue. So this causes what we call a two compartmental model. And this is a simplified image just to give an idea. So when we look at its half-life, because of that distribution that I talked about, it does have a biphasic distribution. So that does lead to a more extended half-life compared to other opioids. So it's not that it is a extended release formulation, but methadone in its chemical form has a long half-life. So typically we would estimate its half-life is around 22 hours, but it can vary anywhere from 8 to 59 hours and last up, and can even take as long as 120 hours before we reach a half-life in hepatic impairment. And one key thing is, despite it having a long half-life, when we're using it for its analgesic benefits, with repeated dosing, we find that the analgesic benefits can last anywhere from 8 to 12 hours. And in the last slide, when we talked about metabolism and elimination, it is extensively metabolized by the liver. So in patients that have hepatic dysfunction, we do want to be more cautious when using it. And to emphasize, this doesn't mean that it's a contraindication, but that just means that we need to be more mindful and be maybe more cautious with the dosing and titration intervals, which we'll dive into a little bit. The main period where we would generally avoid using methadone completely is in unresolved biliary obstruction, because this is the primary way that it is excreted. And in regards to CYP substrates, this is the main means where methadone is metabolized through the CYP enzymes. And key ones to look at is 2B6, 3A4, 2D6, and 2C19. And it also does have minor metabolism through the CYP2C9 and 2C8 pathway. So this does mean methadone does have a lot of drug interactions. So this can impact your clinical decision for considering methadone and or its dosing. And you might notice that I've highlighted a few of these in green. And I mentioned these because there are some pharmacogenetic variations with these types of enzymes. So that means each individual may actually have a different genetic expression of these enzymes, so they may innately have different speeds or levels of metabolism just based off of genetic variability. So this may also add to some unpredictability with how each person may metabolize methadone. And now going on to some monitoring parameters. When we look at methadone, we mentioned risk for QT prolongation or torsades. So things that we look out for potential torsades risk factors are electrolyte abnormalities, patients that are over the age of 68, females, people that may have structural heart disease, or genetic predispositions to torsades, or other or patients that may be taking other additional or concurrent medications that can prolong the QT interval, and patients with a history of syncope and previous histories of a QTC interval over 450 milliseconds. So when we look at these risk factors, patients that have one risk factor have an odds ratio of 3.5 more likelihood of developing torsades, and patients that have 3 or more of these risk factors have an odds ratios of 9.19. So these are things that we may want to gather some history or keep in mind when we are considering methadone in use. And some other predictors of QT prolongation also include heart failure, hypokalemia, hypocalcemia, and also taking other medications with known torsade risk, rheumatological diseases, malignancy, peptic ulcer disease, and patients taking methadone doses over 45 milligrams a day. So looking at monitoring parameters, if we are to start methadone, the priority is monitoring and follow-up. However, there are some recommendations with that, but in the setting of palliative care or hospice, the priority is actually making sure that we align our monitoring parameters with the goals of care with the patient, and also weighed with these risk factors that we talked about before. So sometimes aggressive labs and ECGs for follow-up may not be warranted in patients with comfort-focused care with minimal risk factors. And we always emphasize the risk and benefits should be discussed with patients so they have consent and are aware of the risk and benefits. So typically we generally recommend to do a baseline monitoring parameters of doing an ECG. So we have a baseline QTC interval, and then also obtaining electrolytes, and specifically potassium, magnesium, and calcium, because low levels of these electrolytes can actually cause an increase in the QTC interval or cause QT prolongation. Once initiated on methadone, our recommendation through the white paper consensus is typically to do an ECG 2 to 4 weeks after the initiation of methadone. And also when methadone doses are titrated up to a dose of 30 to 40 milligrams a day, and also at 100 milligrams a day, because those are significant dose thresholds that might have a higher increased risk of torsades. And also if patients develop any new risk factors or signs that may be suggesting of an arrhythmia. And when we're monitoring, we also want to look out for potential adverse effects and then wait sufficient time before reaching steady state, before making any further dose adjustments. And in this case, typically steady state is anywhere from 3 to 5 times a half-life of a medication. And as we mentioned before, in normal hepatic function, it's around 22 hours. So So we recommend doing monitoring for 5 to 7 days before making any dose adjustments. And then for hepatic impairment, we recommend doing 10 to 14 days, also in patients with advanced age, because they may also have a decreased metabolism just based off of the physiology. But I know we did talk a lot about QTC intervals and risk of torsades, which can sound very intimidating and concerning. So there was actually a prospective study at MD Anderson looking at 100 cancer patients, and they monitored ECG changes from baseline, 2 weeks, 4 weeks, and 8 weeks. And the results of the study were at baseline prior to initiation, 28% of patients had prolonged QTC. Medium dose of methadone was 23 milligrams. At 2 weeks, 31% of patients had prolonged QTC, and only one patient had a QTC interval over 500. And then no patients in this study were found to have greater than a 25% increase of their baseline QT interval, and no events of torsades or ventricular fibrillation occurred. Granted, a limitation of the study was that there was significant dropout. So now that we've talked about some monitoring and risk factors, how do we choose who might be a good candidate for methadone? So typically when we're looking at patients and wanting to consider methadone, we think about patients that are having moderate to severe pain, potentially pain refractory to other opioids, patients that have significant renal impairment, or need of a long-acting opioid. So if they're having around-the-clock pain and needing their immediate release opioid very frequently, and also patients that have a high opioid tolerance. So if they're requiring very high doses, for example, morphine, this may be a good option. And also patients that are having poorly controlled opioid-induced adverse effects with other opioids. For example, like we mentioned before, opioid-induced hyperanalergia, and also patients with a true phenanthrene allergy or a morphine allergy. Because methadone is a synthetic opioid, there isn't the same level of risk with a cross allergy with morphine. For patients that we might be a little bit more cautious, again, not necessarily a contraindication, but this just means we would want to be monitoring more closely or being more conservative when we're doing dosing or titrations. So patients that have structural heart disease, a QTC of 450, but less than 500, patients with severe chronic liver failure, history of non-adherence to therapies, patients with sleep apneas, and that can be central or obstructive, and patients that have multiple non-modifiable drug interactions, and multiple non-modifiable torsades or QT prolongation risk factors. Next would be patients that we would probably steer away from initiating methadone on. So patients that have family history of sudden death, congenital QT syndrome, QTC intervals of 500, more than 500 without modifiable risk factors. And then just to reemphasize modifiable being potential corrections of electrolytes or making adjustments to medications that may be contributing to a prolonged QT interval. Also patients that have poor cognitive function and or lives alone without reliable caregiver support. And also the inability to obtain follow-up, active illicit drug use or misuse, specifically cocaine and methamphetamines, because this can also increase that risk of arrhythmias. Patients that are in an acute pain crisis or acute pain management, methadone may not be a great option to think of utilizing first, primarily because of the long half-life and titration time to titration, and then patients that are experiencing acute liver failure. So I just wanted to open up for a few questions that anyone might have. I know that was a lot of information.
Till now, if you have any questions, please ask. So,
Okay.
they were talking about the mechanism of action of methadone, and there are three mechanisms. One is the agonistic action on mu, kappa, and delta receptors. Then it is an NMDA antagonist, and the fourth one it is, third one it also acts like tricyclic antidepressant. So these are the three beneficial actions of methadone. But they also told it can increase QT interval, but if you use it at low doses, the chance of increasing protein level is very less. And the one study which Theo quoted, 70 and sometimes the study. But it is also important to see that the QT interval studies that was mostly done on patients who are on substitution therapy with methadone. And in such patients, they will be taking hundreds of milligrams of methadone. So it is natural that they will have prolonged QT interval. So low doses of morphine are comparatively safer. Um, and there are many risk factors also that the three of us mentioned, which includes cancer, rheumatological disease, structural heart disease. There are many things. And some electrolytes which are important are calcium, potassium, and magnesium. Because if these electrolytes becomes less, then it can cause increased nutrition. And I can see some of the questions, but I think Theo is going to cover it in the coming
Yeah.
slide.
So there's one question on how to titrate methadone. So I'll be going that in a little bit later. One question is pharmacodynamic and pharmacokinetics is true for both IV and oral methadone, meaning does IV methadone have a faster onset? So in this, for methadone, like I mentioned before, it's not a formulation, it's actually the chemical structure of methadone. So when we think of methadone in regards to the titration period, it would still be the same, where we want to wait the 5 to 7 days in normal hepatic function, and then 10 to 14 for patients that may have impaired hepatic function. But in regards to the absorption, maybe onset, the IV would be systemically absorbed in a few minutes, like 5 to 15 minutes, around 5 minutes or so. But in regards to absorbing it orally, oral absorption generally can vary anywhere between 30 minutes to an hour. But again, titration periods and general half-life would still be the same regardless of those routes. Another question would be, can methadone be given in home care patients, as ECG and labs are not always ideally done in our setting? So again, it would be dependent on goals of care, if it's comfort care focused or hospice versus if it's more of a curative intent. If it really is not accessible, that can be a conversation between you and the patient about the risk, but also monitoring if the patient has multiple risk factors that may make you more concerned. But in an ideal scenario, having those baselines would be good, but if it's not possible, then I would say look at potential risk factors. Okay, and then the next question, does methadone have a ceiling effect? So technically there is, there is no limit on what dose that can be used in methadone, but there was a study showing typically with the use of methadone in pain management, there may be pretty substantial responses at doses around 30 to 40 milligrams, but I've had patients that have required higher doses. Okay. And then for frequency of ECG monitoring, that was on the previous slide. Baseline after initiation 2 to 4 weeks. And then when you hit the dose thresholds of 30 to 40 milligrams and 100 milligrams. And then also if there's any additional risk factors. And for recording the slides, I believe that this is being recorded. So you should be able to access this later. Okay, so now moving on to methadone conversions. So methadone does not have a linear conversion ratio. And this is because of methadone's NMDA antagonism, which may provide benefits with reduced opioid tolerance or hyperanalgesia, and also adding neuropathic pain benefits. So opioid requirements may innately be reduced. And prior to this white paper consensus, there was many different methadone conversion recommendations, and they had different dose conversions based on a patient's daily OMEs. Typically when we start a conversion, the main thing that we want to do first is determine basal opioid requirements before converting. And then also after we do that, ensuring that patients have sufficient breakthrough pain medication. So with the white paper consensus recommendations, it generally helps simplify it, but these dose conversions are very conservative. So you can feel comfortable using these numbers, given that they are pretty conservative in its use. So for opioid naive patients, and that's defined by patients using less than the 60 milligrams of oral morphine equivalents, which I'll continue to refer as OMEs just for simplicity. We usually recommend to use an initial dose of 1 milligrams every 12 hours or 2.5 milligrams every 8 hours. And because this is opioid naive, you can use any of these doses. Usually we would recommend to initiate a lower dose for patients that may be older or more frail, or if we have concerns of impaired hepatic function. For patients that are opioid tolerant, that's defined as patients using 60 or more milligrams or OMEs per day. And to break it down, patients using 60 to 199 OMEs per day, and patients under the age of 65 years old, we would use the conversion ratio of 10 to 1. So 1 OME to 1 milligram of oral methadone. And for patients that are requiring over 200 milligrams OME or 65 years old, over 65 years old, regardless of what OME they're currently using, we would do this 20 to 1 ratio, where it's 20 OMEs to 1 milligram of oral methadone. And regardless of the conversion factor, the max initiation dose of methadone that we would recommend is 40 milligrams per day. So even if you do a calculation and it's above this amount, we always recommend to not exceed 40 milligrams for the initial dosing. And things to keep in mind, whenever we switch between opioids, you may have heard of the concept of incomplete cross tolerance and needing to innately reduce an opioid dose because people may have improved response with different opioids. This conversion ratio for methadone already includes that. So you do not need to do any further dose reductions because, again, it is a pretty conservative conversion ratio. And another thing that I want to emphasize is this conversion should only be used in one direction. So from other opioids to methadone, not the other way around. Because it is a conservative ratio from other opioids to methadone, if you did this other way around, then you may cause an excessively high dose. So this is a one direction conversion only. And when we talk about titration recommendations, how fast can we go up and how fast can we make dose changes? It's going to be based on what the patient's current methadone dose is right now. So if a patient's on less than 30 milligrams per day of methadone, then you can increase by up to 5 milligrams a day. And patients requiring 30 or more milligrams, then you can go up by a titration of 10 milligrams. In regards to how soon we can make these dose adjustments, like I mentioned before, patients with normal hepatic function, not to make any of these dose titrations any sooner than 5 to 7 days. And in patients that have hepatic impairment or are of advanced age, because we're worried about reduced clearance or metabolism, no sooner than 10 to 14 days. In regards to drug interactions, so as I mentioned before, there are a lot of drug interactions with CYP enzymes. So a general rule of thumb through my pharmacy school years, some acronyms we've used was GPAC-Man. So that includes grapefruit, protease inhibitors, azole antifungals, cyclosporin, cimetidine, cobicistat, macrolides, amiodarone, and dronabinol, and non-DHP calcium channel blockers. And inhibitors would be medications that will cause a decreased metabolism or CYP activity. So it can cause increased methadone levels. For CYP inducers, another analogy is PS-Porks. So phenytoin, smoking, phenobarbital, oxcarbamazepine, rifampin, rifabutin, rifapentin, carbamazepine, and St. John's wort supplements. So again, if it is possible to avoid using strong inhibitors or inducers for different treatments of other disease states, we always recommend to try to use alternative agents first. But obviously there is going to be some cases where they may be unavoidable, or patients may need to be on specific therapies or started on them or discontinued. So when we talk about CYP inhibition, there is actually a difference in how it affects the enzymes. So typically CYP inhibition, the peak effects can occur 1 to 2 days versus CYP inducers, that is actually affects our protein expression of these CYP enzymes. So the peak effects may actually take 1 to 2 weeks before they occur. But so our recommendations in cases where we're starting an inhibitor or stopping an inducer, so these both would be scenarios where methadone doses we would expect to be increasing. We recommend to empirically reduce a methadone dose by 25 to 33% and monitor carefully. If there's concerns with the reducing the dose and increased pain, we would empirically reduce it because we can always titrate back up once we reach these peak effects. In the opposite direction of stopping an inhibitor or starting an inducer, where we anticipate this may innately cause a decreased methadone level, we actually recommend to just keep the methadone dose where it's at. And if they are experiencing increased pain or withdrawal symptoms, then they should be relying on their immediate dose opioids or breakthrough pain medication while we wait for these effects, and then we can make adjustments as needed at the respective time intervals. So like I mentioned before, there are a lot of potential drug interactions, and those acronyms do not cover everything, but they are a good general basis. But a good resource to check for drug interactions is actually a Flockhart table, which I've included the link for, that you can utilize to see if a medication may be a CYP inhibitor or inducer based off of related to the previous CYP interactions that I mentioned previously. And in regards to QT prolongation risk, Credible Meds is a great resource as well. It has a free mobile app that you can download. And if you are using the website, it may require you to register, but all you need to do is register with an email, and then you'll have free access to that as well. Again, I just wanted to open up for a few minutes for any questions. One question was if there's any drug interaction with ondansetron. So with ondansetron, the main concern is potential additional QT prolongation risk. So some other medications that can also be used for nausea would be prochlorperazine, which doesn't have that same level of QT prolongation risk. And actually targeting dopamine antagonism may actually be more effective for treating opioid-induced nausea if you're concerned about that. The next question is methadone safe in children? Yes, so methadone can be used in children. In regards to the specific dosing of it, I don't know if I would be able to say I can speak on management in pediatric setting. Each time we, yes, Dr. John asked, each time we increase dose, we should wait 5 to 7 days. Yes, that is correct. And then the other exception is if they are of advanced age or have hepatic impairment, then it would be a 10 to 14 day interval. The next question is, how do we provide breakthrough relief when starting methadone? So for providing breakthrough relief, you can still use immediate release opioids to help with that. So a patient can be on methadone for a long-acting opioid and then also have breakthrough morphine doses to supplement. And then examples for conversions, I'll be going that in the next section. So that's a great question too. Okay. So now, excuse me, now going on to practice cases. So in this case, we have a 57-year-old male with history of stage 4 pancreatic cancer with metastasis to spine and liver, presenting to outpatient palliative care clinic with concerns of uncontrolled pain in his back and legs. His history of illness, he's diagnosed with pancreatic cancer 1 year ago. Pain was previously managed well with ibuprofen, paracetamol, and a few doses of morphine. However, disease has continued to progress with lesions in the liver, back pain progressively worsened, and then he took additional doses of ibuprofen, causing AKI. On repeat imaging, they found new lesions on spine and X-ray and MRI, and then he's completed palliative radiation to spinal metastases. So on labs, his serum creatinine was 2.4 with estimated creatinine clearance of 25 milliliters per minute. Sodium 138, potassium 3.2, chloride 98, CO2 22, BUN 50, glucose 170, AST 84, ALT 74, T-Billy 0.4, alk-phos 180, albumin of 3.0, vitals, blood pressure is 119/80, heart rate 75, respiratory 17, weight of 50 kgs. Bowel sounds were normal. Last stool was 5 days ago. On MRI, it showed extensive osseous metastasis throughout the spine, pathological compression fractions of L1 and L3, no spinal cord compression, metastatic lesions involving sacroiliac bones. On physical examination, he had mild temporal atrophy, CV, regular rate and rhythm, lungs were clear in auscultation, GI, faint bowel sounds, and extremities, +1, lower extremity edema, no lesions on feet, neuro exam intact, no current signs of myoclonus. For treatment history, he was initially diagnosed in, sorry, it should be 2022. Lesions considered inoperable. For chemotherapy, he completed 8 cycles of FOLFIRINOX 8 months ago and completed 6 cycles of paclitaxel and gemcitabine. Last cycle was 1 month ago. For radiation, he received 24 units of fractions for palliative radiation 1 month ago. For analgesic history, he has tried gabapentin, did not note any pain relief, and has tried doses up to 1,800 milligrams per day, and all it did was cause increased sedation. Ibuprofen taken in the past caused mild relief, but he was told to stop because of his renal function and previous AKI. He has used amitriptyline in the past. It provided some improvement in his pain, but he couldn't tolerate the side effects of the dry mouth and had some mild confusion. Completed a 5-day burst of dexamethasone for the last week with mineral relief, and then he could not afford a fentanyl patch because of his financial limitations. On pain assessment, on his back, his onset of pain is constant with flares, qualities described as sharp, burning, achy, and pain does radiate down his legs. Severity is typically an 8 out of 10, and the lowest it goes down to is 5 out of 10. Some palliating factors are laying on his side and using his morphine. Aggravating factors is sitting, walking, and impact on his function. His pain is causing difficulty with walking, sitting, and limited ability to do work around the house, and he's unable to work and is having poor quality of sleep. For pain on his legs, he's describing this as continuous, and pins and needles with numbness. He says it feels like sandpaper with light touch. There is no rating pain. Severity is typically at a 2 out of 10 and 5 at worst. Nothing helps with this pain. And then again, aggravating factors is touch and abrasion, and he is having difficulty with walking and poor sleep. For psychosocial, he's currently widowed, has 2 children. 1 daughter died from labor complication, and he has 1 son who he currently lives with and provides some support and helps with management of his medications. And he has previously worked as a carpenter, but due to his disease, he's unable to continue working. For current medications, he's currently taking hydrochlorothiazide, insulin, and he was started on ciprofloxacin 2 days ago for suspected UTI, and then omeprazole BD, and then paracetamol 500 milligrams Q4 hours SOS. He reports using 5 doses a day on average. And for morphine, he's currently on 60 milligrams PO Q4 hours SOS, and he states that he's using 6 doses per day and sometimes takes 7 doses because the pain is so severe. So right now, his main concern is this uncontrolled pain. What interventions would you guys potentially consider? So some things is we want to think about what other potential options can we do to help with his symptoms. So because of the metastases and sounds like some bone pain, we would consider bisphosphonates to help with that, but because of his renal function, it is contraindicated. We could consider using duloxetine for the norepinephrine and serotonin activity to help with neuropathic pain, because he did respond with amitriptyline in the past, but couldn't tolerate the side effects. However, due to his renal function, that is contraindicated. And right now, there's no clear regional sympathetic blocks that can be completed. And right now, it's contraindicated because of concern of active infection. Like I mentioned before, he couldn't tolerate the TCA. And as a side note, we never recommend to use a TCA in combination with methadone because it can cause that increased QT prolongation risk. And also it is targeting similar receptors for activity. And then NSAIDs was helpful for him in the past, but he can't continue this because of his current CKD. And based on his OME requirements, analgesic benefits likely outweigh buprenorphine, and it may be complicated because it can precipitate opioid withdrawal. So when considering buprenorphine, I would say I would be very cautious about this, and that may be a separate topic to consider with using that in pain, but it does have its place in therapy and can be helpful. He's already tried burst dose of steroids with minimal relief, and then he can't afford another means of long-acting opioids such as fentanyl patch. And regarding fentanyl, it may not add substantial benefits for his neuropathic pain components that he's experiencing. So based off of these other options we've considered, it may look like methadone might be a good option for us to consider. So what additional lab tests would you want before starting methadone? Based off of what we already have collected from the patient. Yeah, so someone mentioned potassium, ECG, LFTs. Great, so those are all great recommendations. So for ECG, we obtained that. QT's interval was 463, so it is elevated. Magnesium was 2.0, calcium was 8.6. And because it was a month ago and the potassium was low, it would be warranted to do a repeat. In regards to LFTs, it was elevated before, but because it was a month ago, it may not necessarily be required to do it again. However, if you do suspect substantial changes, such as signs of jaundice, then that might be warranted to do a repeat LFT. Okay, so from our brief discussion before, some discussion points is methadone may be a good option for neuropathic pain, hyperanalgesia, tolerance, and long-acting option for analgesia, and patients with poor renal function. Always try to reduce drug interactions when possible. So when we looked at his medication list before, he was getting Cipro for UTI. We can always try to use other therapies. So example, maybe Keflex as an empiric treatment to treat that. He was getting omeprazole for GERD, but that can potentially cause some interactions with the CYP2C19. So you can consider switching to an alternative therapy such as a H2 receptor antagonist, so medication like famotidine. Baseline and routine labs that we would want to get includes the potassium, magnesium, calcium, LFTs, and an ECG. And again, I would refer to the white paper consensus for those recommendations. And then again, discussing risk and benefits with patients and getting informed consent. And correct reversible causes of QT prolongation when possible. So in this case, stopping the ciprofloxacin because that can add an increased risk factor of that. And other things to consider in this patient, if it is more comfort care, do we still need other medications such as antihypertensive? Because he did have a low potassium, right? So maybe that could be contributing to that, and that might help reverse it. Or you can consider supplementing with potassium to fix that. And then lastly, don't forget to give a bowel regimen to prevent constipation, because methadone is an opioid and it can cause constipation. So we would recommend to start medications like Senna, and you can consider suppository or enema since the last bowel movement was 5 days ago. The concern is because if it is not addressed, that may cause for an impaction and may need digital disimpaction. If it continues to not be addressed, then there may be concern of causing obstruction. Okay, so now going on to calculations. So based off of the regimen that, or the doses that the patient was using before, he was reporting that he was using morphine, 60 milligrams, 6 doses a day, and up to 7 doses because of his pain. So if we do a calculation, we can estimate he's using 360 milligrams of oral morphine per day consistently. So how much would you convert to basal? If the pain is uncontrolled, it's reasonable to convert 100% of the dose to the methadone. And keep in mind, remember that the dose conversion is conservative amount, so that would be reasonable. The times when we would consider using less than that is in scenarios where we anticipate using things that may actually resolve some of the pain or anticipate some improvement. So some examples may be, sorry about that. So some examples can include palliative radiation or chemotherapy. And if we anticipate if they're starting these treatments, pain will improve, then you can consider converting less of that as a basal, because we're expecting pain may be reduced or requirement may also be reduced. But again, just to emphasize, this conversion ratio that is in the white paper consensus is pretty conservative. So regarding what, now that we have an OME, what conversion factor would you use? So based off of the chart, as we mentioned before, in this case, patient is under 65 years old. However, they're requiring over 200 OMEs. So we would use this 20-to-1 conversion. So if we use this 20-to-1 conversion, if we do the calculations, we get around 18 milligrams of methadone a day. And then the things to keep in mind, duration of analgesia lasts 8 to 12 hours. And the final methadone regimen will be dependent on the available formulation. So right now, I'm aware that it's available in a liquid of 5 mg per ml and oral tablets of 5 mg. So we would recommend to just round down to the best fit based on the available formulations. So some examples that might be reasonable is if you did 5 milligram tablets every 8 hours for a total of 15. If you use the liquid or syrup, that gives some more flexibility for patients to get closer to this. So you can use the 8 to 12 hours. So if you wanted to do a twice daily dosing, then you can do 9 mgs or 1.8 milliliters by mouth every 12 hours, or 6 mg or 1.2 mLs by mouth every 8 hours. If methadone syrup is being dispensed, it is recommended to provide them with an oral syringe so they can adequately measure and provide education, so they know what dose to draw up to, and maybe even consider marking it so the patient knows if there's any dose adjustments, providing new oral syringes with marking and making sure to get rid of, discard of old ones. And again, don't forget about providing breakthrough pain dosing. So when we're trying to determine breakthrough pain dosing, if we continued the current dose of the IR morphine, that might be pretty high considering we're adding a basal opioid on top of that. And the intent is the methadone would help replace some of that requirements of this frequent morphine dosing. So a general rule of thumb, based on the total daily OMEs, using a 10 to 15% dose for breakthrough. So if we did a 10% of 360, that would be around 36 mgs. So you can round that down to a morphine dose of 30 milligrams. And then if we just want to double check to see the amount the patient will receive to get sufficient breakthrough dose, if we calculate it, the patient can get up to an additional 180 OMEs. That doesn't mean the patient will take all of this, but they have the opportunity to use it, especially during the initial titration periods. So a final regimen may look something like this: methadone 5 mgs every 8 hours with an additional morphine IR 15 milligram tablets, and they can do 2 every 4 hours as needed for breakthrough pain. Okay, so now that we started a patient on methadone, what do we do with follow-up? So patient notes, once we started the methadone, there's some improvement of pain. It's now at a 6 out of 10 in severity. Previously was an 8, but it's still uncontrolled or still significant for them. So what would we do next? We would want to figure out how much of the IR morphine that they're requiring. So based off of the report, they're saying that they're still needing to use 6 doses of the 30 mg morphine consistent. So how would you make adjustments to patient's pain regimen? So if we did this calculation, that means they're using the 100 mg OMEs. And we want to make sure the patient had sufficient time to achieve steady state before we make any changes to the methadone dose. And in this case, it would be reasonable to do 5 to 7 days. They didn't have, they had some elevated LFTs, but it wasn't extremely high and no concern of cirrhosis or signs of jaundice. So I think in this case, it would be reasonable to do the 5 to 7 days. So we could determine how much we want to convert of this to the basal opioids. So say, for example, if we want to do 50% of it, then if we do the 90 and still use the same ratio that we did before of the 1 to 20, then that would convert to the 4.5 milligrams of methadone in a day. How does this compare to the titration recommendations that we mentioned before? So they were on 15, and the maximum daily dose increase is 5. So even if we used a different percent to increase the basal, we still wouldn't want to go up more than 5. So we would just recommend to do an increase of this 5 milligrams per day. So from 5 milligram Q8 for a total of 15, you can make a switch from 10 milligrams POQ12 for a total of 20 milligrams a day. Any questions? Let me check. Sorry, I am trying to load the chat, but it's not popping up if anyone's probably putting in any questions. One question is, can we add any adjuvant therapies? Yes, so if there are, you can utilize adjuvant therapies. Generally, I would recommend not to put any duplicate receptor activities, right? So SNRI, TCAs, that would also target the same receptors because methadone does cover NMDA, norepinephrine, serotonin receptors. But so other agents can be utilized. We just want to be mindful of if it's going to cause drug interactions versus if it's contraindicated in the disease state. If he didn't have the renal impairment and he's having bone pain, an NSAID would be reasonable to utilize also. Next question is, if patients becomes drowsy on the current dose, what would you do? If the patient's is excessively sedated, right, then the main thing we would want to look at is what is causing that. Is that because of the opioids? If that is the case, then maybe we would want to get some more information, right? So how often are they feeling sedated? Is it constant? Or is it primarily after they take their breakthrough dose? So if the scenario was they're feeling excessively sedated or caregivers concerned each time they get a breakthrough dose, then you can decrease the breakthrough dose. If they're sedated excessively, there's no other possible concerns such as other medications that may be causing it, or if they're having poor sleep, then and they're not using their SOS or breakthrough dosing frequently, then you can back down on the methadone dose preemptively and give it some time and see how they're doing. Is methadone used in non-cancer chronic pain? Methadone can be used for chronic pain, but typically it's more commonly used in cancer-related pain. It can be used, but again, generally we reserve opioids after we've tried other agents first. Do we need consent form from relatives? I would defer that to Dr. Sunil, but generally speaking, if the patient has the capability of consenting, that was probably reasonable. If the relative is a primary caregiver and patient is unable to consent, then you may want to have a discussion about it. But in regards to the legality of it, those terms in India, I would defer to Dr. Sunil.
Sorry, I got disconnected in between, so I couldn't hear what was the question.
And then one more question is, how long does it take for the neuropathic analgesic action to set in? And can we stop adjuvant agents? So I would say waiting that titration period of the 5 to 7 days is when we would notice the full benefits. If they have significant improved pain reduction, or if it's tolerated, I would think it's reasonable to test to see if we can decrease some of the adjuvants. So example, if someone's also on gabapentin, 3,600 milligrams a day, we start this methadone, pain's working, is well controlled, I would recommend to try to taper down on the dose and see if they even need it. If we can reduce other medications that they're taking, great. If they don't need it, I would say titrate down and see to effect, because gabapentin can also add to respiratory depression risk in concurrent use with opioids. Not to say you can't use it, but it's just more precaution to be aware of. Okay, and another question is, does methadone have more neuropathic pain benefits than other opioids? So I would say some opioids have better neuropathic pain benefits than others. Typically, methadone, I would think of one that helps with neuropathic pain. Buprenorphine is another option that works well. And tapentadol is a great option also that can help with neuropathic pain components. After what duration will we stop breakthrough dose of morphine? So I would say typically we always want to keep a breakthrough dose of morphine just because people may have breakthrough pain with methadone. They may not necessarily need to use it all of the time, but I would still recommend for them to have that available. If they aren't using it frequently at all, you could also, or needing it, you can also reduce the dose of a breakthrough. Okay. So I know we're running a little short on time, but I wanted to also include some additional scenarios. So in the cases of an unavoidable drug interaction, if the patient's on the 18 milligrams of methadone a day, what would you do if your patient was started on fluconazole and there was no other alternative treatments that you can use? So back to fluconazole, that is a major CYP3A4 inhibitor. So based off of this, we would empirically reduce by 25 to 33%. So if we did sorry, I think the numbers are off on this, but we would do the reduction of the 25 to 33%, and we would reduce the dose. So I apologize about this slide. I think the numbers are off. For very high doses, in a scenario where patients requiring 1,200 milligram OMEs of methadone, or of morphine OMEs, if we did that 20:1 ratio, we would get 60 milligrams of methadone a day. What dose or regimen would you start on? Again, I want to emphasize that regardless of the conversion factor you're using, the maximum initiation dose we would do is 40 milligrams a day. So 60 is too high to start. So you would cap that at the 40 and do divided doses. For patients that are opioid naive, so in this case, 37-year-old female presents with metastatic head and neck cancer for pain management. She was determined to be a good candidate for methadone as it might help with their neuropathic pain. Her pain is rated as 7 out of 10. So current opioid use for morphine, she's using 7.5 milligrams every 4 hours. For breakthrough pain, she reports using 6 doses, so a total of 45 OMEs. Past medical history of head and neck cancer, CKD, hypertension, type 2 diabetes. So what methadone would you start? So again, based off of that table for opioid naives, you can do an initial dose of the 1 every 12 hours or 2.5 every 8. And just for us to do an example calculation, what would we do? What would we use if we did use one of those ratios? So if we used the conversion ratio, again, this is just in theory for us to test out with the 10:1 OME ratio. If we did the 45 and did the 10 ratio, we would get 4.5. So that would still be within the dose recommended range. So you could consider doing the 2.5 twice a day. So discussion points about this. When we're doing calculations, it's important to evaluate the total daily OME requirements and factors that may impact opioid methadone conversions, dosing, and titration, such as age, hepatic function, drug interactions, etc. Methadone does not have linear conversion factors, so we would recommend using the provided recommended tables. And again, when making adjustments on doses, make sure that you're waiting to achieve steady state. So at least 5 to 7 days or 10 to 14 in hepatic dysfunction or advanced age. Dose titrations are dependent on the current methadone dose the patient's on. And again, the conversion ratios are only from other opioids to methadone. And again, just to emphasize, don't forget to add on a bowel regimen to treat constipation. And I think the slides will be provided, so I don't think we need to spend time on them. Does anyone have any additional questions?
Sir, I am Dr. Ragesh. I'm working as a palliative care physician. One question I want to ask is that is methadone used as a replacement to morphine, or those patients who's not tolerating morphine are unable to give morphine? Can we use methadone instead of morphine as a first line? Or if we start with morphine and if it's not tolerable, the above-based precautions are there, we switch out to methadone, which is the best option for that?
Yeah, so in regards to, so I would say it depends. So if there's no, like no additional factors that we would think about methadone, right? So if they have normal renal function, we're just thinking about methadone as the first opioid we want to use, and there's no like primary neuropathic pain, then I would say I would probably try morphine first and see how that's effective. But say if they haven't been on any opioids, they have renal failure on dialysis, and they have neuropathic pain components, I would consider starting off the initial dosing recommendations for opioid naive and start methadone.
Thank you, sir.
Any additional questions? There's another question for what are the legal implications of prescribing methadone in India? And I'll defer that to Dr. Sunil.
Yeah, you know, in India, we have ENDs. ENDs means essential narcotic drugs as per NDPS Act. That is Narcotic Drugs and Psychotropic Substances Act. So we have 6 ENDs. Those are codeine, oxycodone, hydrocodone, morphine, fentanyl, and methadone. So as per if you know how to prescribe morphine, it's so all these opioids coming under ENDs, it's the same legal implications. So when you prescribe an opioid in END, it should have some details like name of the patient, age, date, then what opioid are you using? It should be in capital letters. What strength you are using, and how many days you are providing, and how many numbers are you providing. Then you have to sign your name, your medical registration number, and address. So those are the needed details as per NDPS Act.
Additional question is methadone tablets and syrup available in India? Again, I will defer that to Dr. Sunil. And then another question is who can prescribe and dispense methadone?
Okay. So actually, anybody who practices modern medicine or even who has a BDS degree can actually prescribe methadone. But the question is, where would you get it? It is available only in recognized medical institutions. So, if some of you prescribe, and methadone is available only in very few institutions in India, uh, maybe less than 10. And we use methadone in our institute. But if somebody sends a prescription for methadone who has not, uh, who doesn't have any experience in palliative care, we will not provide methadone. It's our duty to ensure that that is used properly. So the question is, where would you get it? So if you have an RMI status, that is recognized medical institution status, you can stock and dispense all the essential narcotic drugs.
And I think the last question is, does bowel side effects like constipation more with methadone compared to morphine? So I would say in regards to risk for constipation with opioids, I would say that's something that should always be preemptively treated with laxatives, even providing it as SOS or as needed, because that is something that can occur with all opioids and is not a side effect that reduces with continued use or tolerance to the side effects. So I would always recommend to make sure that you provide an adequate bowel regimen. Okay, and any additional last minute questions? Okay. So I think that is everything, Dr. Sunil. Sorry, and I also have one more slide because I know this question may pop up later. As I emphasized, the conversion ratios before were from other opioids to methadone. Some people may ask, well, what if we need to switch methadone to morphine? So there was one study that did a conversion and looked at it, which I provided the reference down there. But if you are doing conversion, there is a proposed conversion of 4.7 to 1 that can be utilized if that is needed. Great. Thank you, everyone. And that's everything I have to present on.
That's it.